And with this echo format, if you guys have questions during the session or during the little chat here from Dr. Rice, and I'll pop in at some points as well to talk from the therapist perspective, you can put them in the chat. And then any like specific questions that you want to have like back and back feedback, just save that for the end of the presentation. We'll have some time set aside to have some conversation.
All right, and so I'm going to talk about cerebral visual impairment and red flags and clinical indications along with LC. Let's see, I assume you have to forward the slides. Is that?
Yep.
Sorry. All right, so I'm Melissa Rice. I'm an associate professor within the Division of Pediatric Ophthalmology at Cincinnati Children's. I'm part of the CVI team here, team clinics we have. My clinical research activities in the area of CVI, also amblyopia, strabismus, and myopia. And Elsie is one of our fabulous outpatient OTs who is part of our CVI team, as well as evaluating them in her clinic, and she does low vision clinics as well. And our objectives are, we hope that you're able to identify at least 3 atypical visual behaviors that can be present in a child with CVI and describe risk factors for CVI in infants and young children, and describe the screening tools and clinical observations that can be implemented into clinical practice. So, why should we care? Well, CVI is the leading cause of visual impairment or low vision in children in developed nations. And the prevalence is just increasing, as we save babies younger, and they're at high risk of having CVI. So the other problem is this condition is underdiagnosed, and it's more prevalent in our underserved populations. And we actually did sorry, this is an aside, but we published an article that we did where we surveyed pediatric optometrists and ophthalmologists in the US, and unfortunately don't receive a lot of education on it. So the practitioners can be uncomfortable making the diagnosis, making the call as well. So children aren't getting the services they need. In our retrospective study, the average age of diagnosis was about 4.5, which is, outside early intervention services. And so they're not getting privy to that, unfortunately. So we hope to change this in time. All right. Okay, so CVI is a brain-based visual impairment. It's damage that occurs to the parts of brain dealing with processing and integrating integrates visual function. It can be very severe, where you see a child and they're staring at lights or they have minimal visual responses. And it also can be very mild, where they don't really have impact until their school age, and the worksheets, get more crowded, and there's more issues that way with the clutter. The other thing, like when I was in school, which would have been 29 years ago when I would have started, which is insane, but we thought CVI was the absence. Like if everything looked good on the front part of the eye, but they're not responding visually, it must be CVI. That's what we're taught in like one tiny little paragraph in a book. But as we know now, it can occur with other visual impairment. So it's important to know if a child has nystagmus or optic atrophy, they can also have CVI. So, and sometimes it can be a little tricky to differentiate, but as you evaluate and stuff, it becomes clear that there's more than one thing going on. Okay, so this is exciting. This came out in mid-November 2024, and how many members? 4 members of our team were part of the NIH workshop for this, and the NIH came up with a definition of CVI, and it's kind of long. It's not as concise as the European definition, but basically it says, there's 5 parts, that it's a spectrum of visual impairments, and we can include this, we can send you this article if you like too, that affects the development of visual processing pathways and characterized by deficits in visual function as well as functional vision, so like processing that visual information. And that the visual dysfunction from CVI is greater than the comorbid ocular condition, so it has to be bigger than the nystagmus or, optic atrophy. And it can manifest as lower or higher order defects, leading to characteristic behaviors. I want to make sure I hit all of these. And it can be comorbid with neurodevelopmental disorders. But it's not a primary language of like disorder of language, social communication, or learning. The underlying neurological insult of the brain might go unrecognized because sometimes MRIs, like this current technology we have, cannot pick it up or get undiagnosed till later in life if it's more mild. So it's broken down to two visual pathways, the dorsal stream and the ventral stream, and we'll go into that in the following slides here. The dorsal stream is the where pathway, right? It goes occipital lobe, which is the back. I don't know if my circle is really great, but right back there at that blue, dense blue circle, and through the parietal lobes. So that helps us analyze the size and direction of objects, location of objects in our visual space, and the visual guidance of movement. And when we have damage to it, you have difficulty handling lots of information at the same time, and then visually mapping where you're going in space. So that could get in the issue of like orientation and mobility, like navigating through schools if they're school age, communication between vision and movement, and the communication between sight and decision making. So children with that damage are one thing at a time. They're kind of like babies, like infants, where they're one thing at a time, right? And and when they're doing one task, they can be less aware of other things. And the ventral stream is the what pathway. So you have occipital lobes to the occipital cortex, sorry, to the temporal lobes. And that's our visual library, remembering all our friends in school, our classmates, processing physical attributes of an image, a language processing, and visual memory and identifying emotions. Some more examples, they could have difficulties telling like a cat and a dog apart because they, theoretically all have tails and ears, and then recognizing faces or facial expression, emotions. They might have a hard time socially if they can't recognize if a person's happy or annoyed with them. Visually recalling a route and picturing what objects are in a drawer. You know how you know where your things are in your kitchen and you know exactly where the different things are because you have that piece of information in your brain. That can be tricky for them to find things. And I'm going to pass it over to Elsie here.
Yeah, so I'm just going to pick up. And so Dr. Rice had mentioned within kind of the diagnostics and understanding of the diagnosis of CVI is that there's different visual behaviors that we can see that characterize CVI. And while we're not having every single visual behavior listed here, we have on the next two slides just some typical ones that we may see in kids in CVI or who are kind of showing those signs, and then what to look for. I think clinically it's good to be able to, work with a child and take in the different things that they're doing, and then we can kind of look at those and see if they are having some of those signs of CVI. So we have this in this chart so you guys can kind of reference it if you are feeling like maybe you have a child that you're seeing that you're having some concerns for visual processing or CVI. And so the first one is children with CVI may have atypical light gazing or more preference towards light. And things that we look for is if they have improved focus on toys that have lights. Are they looking up at ceiling lights frequently? Often they may do this when they're fatigued or if a task is too challenging. What we kind of see is that lights are really stimulating and it's a lot easier to take in the visual stimulus of a light versus a toy that may be presented to them. And this can include light sources of all kinds. So obviously toys, ceiling lights, windows, screens of tablets may have like a stronger preference or engagement compared to non-lighted objects. We may see variable visual attention, so differences between looking at things that are more simple versus more complex, Or is it a single picture? Or is it a picture book with a lot of like a visual scene in a background that's really busy? Does their attention change based off what they're looking at? We may see that kids with CVI have a lot of compensation behaviors with either their touch or hearing. Sometimes families will say that they think their child only really recognizes them from their voice versus really knowing what their facial features look like, or they compensate with their hearing to identify when someone's nearby, or if a toy is playing with light, they are playing and has some noises to it. They may turn their head towards it and direct their attention to it, but they may not be using their vision. They may just be directing to the noise. And we also will see kids that'll use their hands to kind of touch and explore their world more than using their vision to really understand what's around them. Another behavior that we would sometimes see and look for with CVI is being able to look and use their hands at the same time. So if we think about if our eyes are our brain is having a hard time understanding what our eyes is sending back to us and what we're looking at, we may have a hard time using our hands and eyes together because there's a lot of effort put into looking and focusing on something and understanding something, and then also coordinating the movement to move our body. So we may see kids look at an object, look away, and then reach towards a toy, or we may see that during fine motor tasks, our eyes wander away from what we're looking at, or they aren't looking at what we're doing, which typically won't help if we're trying to learn, having a precise movement to place a toy in a container or match a puzzle, or learn how to write our letters. Some additional behaviors that we may see is increased attention to moving objects. So we may notice that if a toy has a spinning component, we may look at it better. We may see that kids, similar to ceiling lights, is they may fixate or really stare at ceiling fans that also have movement. They may be a distractor for them in different environments. We may see that even like videos is something that they can focus on a lot easier than a book or a picture. But sometimes that movement is a good stimulus that can kind of make it easier to understand what we're looking at. Sometimes in kids with what we would consider kind of lower level CVI, they may have specific attraction to individual colors or better ability to focus on a preferred color. And this may come into play with single colored toys, such as things that are red or yellow, or even toys that provide higher contrast may help maintain their attention. We may see in CVI that close viewing or having things closer to them is better for them to be able to actually focus and fixate on them, or difficulty with seeing things at a further distance. And then with kids with CVI, we may also just see absent visual curiosity. So when we have challenges with understanding what we're looking at, being curious and wanting to explore and visually trying to understand what we don't understand is more challenging for these kids. So we may have a strong interest for familiar toys, or we may have decreased interest to kind of look around and try to see what's around us, or a new toy may not be as exciting for us because we don't quite understand it.
Okay, so medical history. So if you see these in the medical chart, I think your mind should automatically go to looking for CVI type behaviors. It's not a slam dunk that they'll have it, but some of these are more so than others. One is periventricular leukomalacia. It can also be called PVL, or you often see PVL in the chart. It can be called white matter damage of immaturity or periventricular white matter injury. This occurs in preterm babies less than 37 weeks. And kind of an interesting note too, if there's PVL, you will likely see a lower visual field defect, or like in motion trouble with a lower field. The HIE, hypoxic ischemic encephalopathy, is diagnosed in kids that are over or equal to 37 weeks. It's a disruption of the brain blood flow, and that can also have that lower field defect. Another one is CVA, or stroke, that puts a child at risk for CVI. traumatic brain injury, depending on severity and location, and non-accidental trauma, unfortunately, as CVIs often a sequelae. Meningitis and encephalitis are infections of the CNS system. So CMV, rubella, herpes, toxo, and then if they had a bacterial infection, that typically has a worse prognosis. But that is a risk factor. Metabolic disorders, low blood sugar is the most common in infancies, which is the second day after birth is the most common time. But there's also mitochondrial disorders, lysosomal and perioxymal disorders. That's definitely a risk factor. Genetic syndromes, not all genetic syndromes, but genetic syndromes affect the brain. You know, you don't really always pick it up on MRI, but it's something to take into account. And sometimes we find that these can be a little tricky because sometimes they have just a lot going on, like a lot of the kids we see, and you have to kind of sort it out. Is it really do they really have CVI or not with the visual processing? But Williams syndrome can have dorsal stream dysfunction. That's been documented with impaired visual search and guidance of movement. Seizures disorder, typically, or epilepsy, typically uncontrolled. That is the big thing, especially in infantile spasms. That can cause diffuse injury if severe enough. The onset is typically before 1 year of age, and the seizure control can be poor. But something we see clinically as well is the kids that do have seizure disorders and they have CVI, if it's poorly controlled, their CVI they have a hard time processing the visual information. And then if the specialists, the neurologists that are managing this, if they're able to get under better control, we'll see better visual function and better visual processing. Hydrocephalus is a risk factor. There are a lot of kids that do have this that are preemie that don't end up having CVI, but it's something to keep in your mind. And that can be from, intraventricular hemorrhage, infection, tumors, head injury, and, and that can cause visual defects as well, or visual field. The structural brain abnormalities, some of the names like schizencephaly, polymicro gyria, lissencephaly, and there's more, but those are risk factors. And in utero drug exposure, that addiction and that exposure, while they're developing, can damage the brain. And there was one study that said 25% exposed to methadone showed features of CVI. I can tell you we do see plenty of kids with in utero drug exposure. They don't all have CVI. Sometimes it's more attention related and, some of the other aspects of sequelae of that exposure. So this is our retrospective study where 194, we were able to go through all of their chart. And in our population, we ended up grouping it to brain injury, which would include trauma, stroke, IVH, tumor, aneurysm. And that was our highest percentage, 28%. And then hypoxic ischemic causes were about 20%, abnormalities, structural were 17, genetics was 12. And then the seizure piece was 5.7. And to tell you about that, like sometimes we went back to see were the seizures related to genetics, were the seizures related to structural. So we went to like the primary root cause with this group. There was CNS infection, about 6%, intrauterine drug or alcohol exposure, about 5%, and brain volume loss. And then PVL, when we could not figure out what caused the PVL, because there's usually a cause of PVL. Those were our two little patients there. But 48% of kids in our population had CP. So it's, in children with the diagnosis of cerebral palsy, we need to be cognizant of checking for CVI. And so this kind of goes into that too, concurrent medical conditions. CP is huge. The Perkins white paper reported up to 70%. And so depending on what you look at, it's like in our population, it was about 50%, up to 70% of children with CP have CVI. So I think it's something for all of us providing care for children with CP to be mindful to watch that. And if they don't have any early signs that are more severe, maybe have them checked more thoroughly when they're like 5, 6, getting into school. Prematurity is also a risk factor. The earlier you're born, the higher the risk, but like extremely preterm is less than 28 weeks, and very preterm is 28 to 32 and 32 to 37. And also with that, I would look, did they have an IVH? And in our group, the ones that it was more prone to having IVH grade 3 or 4, like more severe IVH due to prematurity. And prevalence is 21 to 47%, depending on what study you look at. Screening questionnaires. I love screening questionnaires. They're not perfect, but I feel like it's something we can give parents to fill out and get some information. Clinically, like experience-wise, some parents are very observant, and the questionnaire can be so useful. Other parents don't always see it, and so sometimes it comes back in negative, and the child's staring at lights. And I think sometimes the parent thinks it's just developmental. But so that's when you just use your discretion of, is this useful information or not? So here's a few different ones. There's the pre-verbal visual assessment questionnaire. I'll go into it. The TEACH, and the kind of umbrella term is the Dutton questionnaires. Gordon Dutton is an amazing neurologist in Scotland. I think he's officially retired, but he's not really retired. CVIscotland.org is his website. And Scotland actually funds the website. And so there's a bunch of great information on there. Can't recommend that enough, but we'll talk about those in the next slides.
And I'll also say we have copies of these questionnaires that will be on that IACO site. I have them under a discussion board, which I'll show you guys later.
Awesome. Okay, so the previous as a 30-item parent questionnaire, and it's actually not specifically for CVI, but it's to detect abnormal visual maturation in infants, birth to 24 months corrected age. It's been shown to be valid and reliable, specificity of 80% and sensitivity between 64 and 79%, depending on the age category. And then let's see here. Go to the next slide, because that's where I thought I deleted that. Okay, so the questions relate to 4 domains, and there's visual attention, and these are going to sound familiar the more we talk about CVI: visual communication, visual motor coordination, and visual processing. The little top area here says what question on the questionnaire applies to visual attention, and then what question for visual communication, and each of the categories. So what you do is you add all the positives. So I go to that box and I will check off all the yeses corresponding to the numbers. And there are some numbers here, like 6 and 7 are in, the first row and the third row. And so there are some numbers that are repeated. And then you just total them up, all the positives, and then you get the second little picture there says 2 to 4 months. This was designed in Europe, and so you go through and you're gonna like say, okay, say on the first one they got 3 right. Or 3 yeses. So you go to the number 3 and you click that, but you're in a darker gray zone, which we call black, area of concern. And then the lighter gray is continue to monitor. So like watch and wait, let's see if they continue to improve. But black is considered, they did not pass that at all. And then if they get 6 of the questions right, at that age, they are age appropriate, considered age appropriate. Now, like any questionnaire, you want to correlate it with what you're seeing clinically. I don't think questionnaires are slam dunks, but I think they can provide a lot of great information and also support your concerns, and easy for families to understand. But we'll go to the next. So this one's great for our littles, 0 to 24 months. Teach CVI, you can find it free online. There's the website down there, teachcvi.net. This has not been validated, but they're based on the Dutton questionnaires that we'll see here in a minute. They have divided up. There's some groups, and we have a study we're presenting at ARVO in May, looking at like how reliable they are and the CVI population. But anyway, Teach CVI 1 is for non-ambulatory children. Teach 2 is 2 to 6 years developmental age, and Teach 3 is 6 to 12 years developmental age. And then the full Dutton questionnaire is the inventory of visual function, and it has a higher sensitivity because you have a full questionnaire, but it's a lot of questions. Depending on what study I pulled, there's between 30 and 50 questions. It's so I was trying to get a hard number, but I tell you everything I found was a little different. But anyway, it's a long one, and it has a lot of things about ambulation, which aren't really sensitive to the kids that don't have are non-ambulatory. That's what I like about the Teach one better. And actually the previous 2 for the youngers. But a study was done and they did 5 questions of those, and it was pretty good. Like, it didn't have an overlap with social communication issues for children with autism. Children with autism can have CVI, but they don't always have CVI. And then it samples mainly dorsal stream. So we'll talk about the 11 questions next, which is one we've been using a lot. And it works really well for kids that we have concerns of higher visual function, like higher visual processing. This is done by Arvind Chanda out in San Francisco. It's a higher visual functioning question, inventory 11. And this is based on the Dutton questionnaire. And he has been looking at this and feels like it's discriminates the visual behaviors between children with CVI and typical children. So there's some kind of introduction to reference, like to questionnaires. They are not with, how everything is. You're always looking to improve these things, but they can provide you useful, and also they can help your history taking. If you can get a questionnaire done, and actually the OT team has been amazing and gotten it set up where we don't have iPads for ophthalmology registration, but OT does, and they can assign questionnaires when they see somebody coming in for a CVI evaluation, and it automatically assigns it. So when the parent checks in, they do the questionnaire and they can import it into their Epic note, which is really, I have to do it the old school way when I'm in clinic, but I do it while they're dilating. And but it's good information. And then you can look at what was positive and expand on that, to help your history taking, because I know that can be lengthy. All right.
Thanks for presenting.
Of course.
I think before I open up to questions for Dr. Rice, I'm just going to show you guys quickly where you can find these resources that Dr. Rice was talking about. So if anyone joined the call today from the iEcho website link, you could find it here. So CVI Echo. Every week when we have a session, you can join here, but then we'll also have the slides where you can download right here to access the place where I'm going to put handouts, because this content thing, every time I put a document into it, I think it sends an alert that something's been posted. So instead, there's going to be a weekly discussion thread up here up top. Or not a weekly, every session we'll have a discussion thread. So if you go to conversations, I've put it in here already, but I just have listed the different things that are here. And each of these questionnaires, including just kind of like the description in the manuals as they're available, have been uploaded to this page. I've also included 2 of the papers that were mentioned in the presentation. But if you guys are interested in downloading these and trying them out, you totally can. If you guys have any other questions that pop up beyond the Q&A period today, we do have, this is a discussion board, so you can type in a response and we'll kind of keep an eye on it, and we can have some question time between the downtime before our next session. So I'll stop sharing that. And I think what we'll do is we'll do about maybe 5 to 10 minutes of questions. If anybody wants to, someone can unmute, or if you want to raise your hand, we can kind of coordinate who goes first. But if there's any questions for Dr. Rice on either screening for CVI or kind of risk factors, or kind of when a child may be more prone to CVI, we can have a few minutes for that.
I have a question. So, how is a child first referred to either Dr. Rice or to your low vision clinic? Like, how does that start?
We like typically the way the referral comes in is sometimes they'll be referred by an ophthalmologist or an optometrist in the community. But other people can refer. We do like them to have a baseline dilated eye exam with one of our colleagues out in the community, prior to coming in, because for our team visit, we do not dilate them. We really focus on trying to go to good visual acuity. We like to look at, we'll talk about more next time too, like contrast sensitivity, the grays in the middle of black and white. Are they able to see that? We like to get a thorough like visual function. What is their visual function? Because I know and when I'm in a like busy regular clinic, high volume, and a CVI kid gets on my schedule, it's hard to do that testing just because it takes a period of time. And when we're in our clinic, we can control the setting, we can adapt the surroundings, we can take them to a small room that has, less lighting, and, we can take the time needed to get those measurements. Because I love when I can provide more than, visual behaviors, more data
Okay.
for their TBIs and everybody, their parents.
Are you the only ones doing it in Ohio, or are there other places doing it?
We are the only one that has it set up like this. My colleague and mentor, I'd like to say, Terry Schwartz, who's a pediatric ophthalmologist, brought this to Cincinnati Children's. She had started this in West Virginia, and because there was such a need, and when she practiced down there for a long time, and it was kind of like a traveling clinic, and she had funding, and then when she came to Cincinnati Children's, she brought it on along with Dr. Lusk, and we got the OTs involved, and then the Children's has really supported it. We've had other institutions reach out to us as we've gotten to know people in the CVI community, like CHLA out in LA is trying to put one together. Boston Children's is trying to put one together. But it takes kind of a lot of resources, and it's only like 4 patients on a half day. So, it's not a great financial
Mm-hmm.
invest, that way. But anyway, yeah. And it's grown since we've done it. So we have, how many clinics do we have a month of CVI? We have one, two, four
I think
half
we
days.
have four now. Yeah.
4 half days. Okay.
Yep.
Have CVI, and then we have the low vision, like traditional low vision is separate.
Mm-hmm.
Yeah.
Yes.
And I'll just reiterate that, yeah, anyone can refer. We have parents that refer their own kids. Doctors, not just at Children's, but from anywhere, refer. OTs, PTs, teachers of visually impaired. Really anybody can make that referral. We just, before they come in, we do try to get that dilated eye exam from somewhere. Again, not necessarily from Children's, but if they've had an eye exam, anywhere, as long as it was dilated, we can take that. So.
Do they just go to a certain website to make a referral, or how does that?
Yeah, so Mel, right? All of our referrals still go through Melody Claire, right?
Yes, yeah, she's currently out, but
Yeah.
we have Fred Noor who is stepping in at the time being, and we have a website. Let me look for it. We
Yeah,
just
and
put
there's like a phone number and an email that you can use that it will go for all referrals for anything vision related, low vision or CVI for the clinics.
Yeah, and we have I could put it in the chat. We actually have this website here, and it has our phone number. We have a dedicated line. Here is, wait, is that? Actually, this might be a different one. That's the OT. Sorry, I grabbed the wrong one, but that's a good site too. Let's
We
see
can
here.
definitely we can pull that information and share that
Okay.
within the discussion thread for you guys if that's of interest.
Yeah, here's our clinic.
I do know so there were some other questions in the chat that I want to make sure we get to as well.
Oh, thank you.
So Anne Marie, you had asked on our team who typically does the questionnaires, is a clinician or a doctor. Um, it just kind of depends on who the kid would see. If I'm seeing a kid as an occupational therapist, I would administer the questionnaire, but all these questionnaires are actually caregiver report. So the caregivers for all the ones that we had shown, they're the ones that are saying, um, this is my perspective on how my child interacts with their world and uses their vision. Who administers them, I think it would just depend on who is seeing them for their visit and who catches those potential concerns for CVI first. Sometimes as an OT, I'll kind of see some red flags for CVI just as a kid who comes onto my caseload who has like a high risk diagnosis or CP, and I see some CVI type behaviors, and I'll have a family fill out the questionnaire. And then I can share that with their provider if they're already connected with ophthalmology here, or I can share it with whoever their doctor is. But they are family filled out surveys. And then Janetta asked if these screeners require specific training to administer them. And they do not. I think the main thing is just familiarizing yourself with them and then being able to explain to families like why you're doing them. So I think from the a therapist or early intervention side of things, just being able to say, you know, we're maybe noticing these different visual behaviors and we know they have a medical background where there's maybe kind of that neurologic background, that basis. So let's just see this survey and see if there's anything that pops up that we maybe want to be having an eye on. And then based off those results, you just want to be able to be prepared to say, like, what do we do next if there are those concerns that pop up? And then another question, Dr. Rice and Kelly, what we may want to see is if someone had asked if there is a resource list of practitioners in given areas who are trained or educated in CVI, not just vision specialists, but optometrists, ophthalmologists. I think we're always trying to find more people across the state, and I think that's one of the big reasons for this training and finding people across the state of Ohio is so we can find out different information and resources. So even if any of you guys know any providers in your area, whether it's therapists or doctors that families have gone to for CVI beyond us, because we know it's not just us, and we know it's not feasible for it to be just us in Ohio. So if anybody has contacts, please let us know, but we can also try to pull together a list and put that as a part of our discussion thread for the week.
And I would say that any pediatric, any optometrist all optometrists should know something about CVI. Those that focus or did a pediatric residency should know a higher, should have more thorough training on it. And then pediatric ophthalmologists should be familiar with it. I have to say that there is definitely a range of comfort on pulling the trigger on the diagnosis. And so if the family feels like they're not getting, because we have patients that come from other places to get the diagnosis. Not that we're going to just give it if they don't have it, but for a second opinion. And so, our goal, our desire as would be that all optometrists and ophthalmologists are comfortable making the diagnosis, but I can't say that's a standard rule, unfortunately. And then there are some low vision specialists that also see kids with CVI that might be affiliated with Dr. Lust. Kelly, do you know, like with the blind and visually impaired, like are there people in that realm that would be comfortable making a CVI diagnosis?
So it needs to be an ophthalmologist or optometrist. So
yeah, but I was thinking like at the school, are there providers at the school, like the Ohio school?
Ohio State School for the Blind. I think they do have a provider that comes in and does eye exams for them. I'm not sure if they do diagnoses. Usually I think it's also only for the students that already go to that school. So unless they had an ocular visual impairment as well and already went there. But yeah, I mean, I can see how that could pop up if they're like, there's something else going on besides, the ocular vision impairment, that they could diagnose that. Yeah.
Okay.
Yeah.
The
And
other one
speaking
that comes to mind for me is like Cleveland Sight Center. They may have some more resources surrounding CVI if you're more northern.
yeah.
Yeah, and I would think that there are some great practitioners at Nationwide and
Mhm.
Dayton and because I know the team that's now at Dayton, Brenda Connors, and she's a great pediatric ophthalmologist. There's some great people there that might, be able to help you out at the different in Rainbow Babies. Did I miss something?
Going to speak to Hannah's question. It's really any age. We can diagnose infants, we can diagnose toddlers. Sometimes if there's questions about if it's potentially something else, we will delay that diagnosis just so we can kind of investigate or have, let the family investigate other options so that we don't rush to that diagnosis. But yeah, I mean, right, Melissa? I mean, we see very, very young children. I mean, sometimes just a few months old. And we can definitely make that diagnosis at that point if if everything is, in order, we can get enough information. So
Yeah.
I will say we tend to have some issues, especially when kids have an ocular visual impairment. So I know Melissa mentioned that a lot of times you can have the coexisting conditions. And what happens a lot of times is we have kids that get diagnosed with one or the other, and then the secondary diagnosis ends up being the one that doesn't happen for a while. So, I mean, we've had 17, 18-year-old kids come into our regular low vision clinic because they've had low vision their whole life with an ocular vision impairment. And we literally realized at the low vision appointment, oh my gosh, this kid also has CVI. And there's certain things that, they've struggled with their whole life, that it was like, it wasn't just, the eyes, it was the brain also causing some issues and stuff. So I think same thing with CVI. Sometimes we get a kid with CVI that then later we realize they actually have, ocular things happening as well, but the brain was so involved originally that we weren't even able to, really focus on the problem with the eyes. So yeah, there's definitely kind of a range of how that happens, and it's like a huge puzzle, it seems like, most of the time, to figure out if it's eyes, brain, both, or something else entirely. I know we have a lot of kids that come in that also, they have a suspected autism. That's one that's very common, that CVI and autism have a lot of things that overlap. And sometimes we're like, we don't really know. We've got to, gather some more data to figure out, what's actually happening here. So.
And I would say, Hannah, too, is that sometimes there's delayed visual maturation, right? You get a child that spent a lot of time in a NICU and they just didn't have the same visual experience. And so they're a bit behind. So we've actually started using the previous in our NICU follow-up clinic at 6 months of age. And so there are some kids that have come that were positive, but then I saw them and they have a heart defect and they don't have any brain-based issue. And it's more of a delayed visual maturation. They're just finally home. It took them 6 months to get home in that enriched environment where they're getting stimulated and not in a hospital room. So, we are a little cautious on diagnosing if they're really, really young, unless we're 100% certain, if they've got a severe brain malformation that's slam dunk CVI, or it's just obvious it's CVI. We want to get them in early intervention as soon as possible in those vision services. There have been ones that are a little grayer where I'll give the diagnosis. I'll have a honest conversation with the family that they have CVI behaviors, but it's a little tricky to sort out because they are so young. But I really want them to have that early intervention with the vision services, to add that to their EI visits. And then we're gonna keep evaluating and monitoring them closely, and we might remove that diagnosis at some point. Most families are most want whatever they need, and I feel like there's some that don't want that extra diagnosis, but I'm like, they can just tie it into your, visits. Anyway, usually they're all in, like, let's go ahead and do it. And they understand why, if it's a kind of a gray area. But when they're real little, if it's not, if they're already kind of getting services and they're doing well and it's not profound and it's kind of mild, we usually say we're going to keep monitoring this, but we just, it's on our list to watch. but we can't diagnose because they're, it's maybe a higher functioning. Those kids are harder to diagnose when they're babies, because, and then one would argue, do they even need the services if they are only going to have problems with worksheets, when they're in kindergarten or maybe second or third grade. So, but we do careful watch and wait with those if we feel like they might be at risk.
I think one last thing is in the comments after I said Cleveland Sight Center, Amanda brought up a good point that sometimes kids may get diagnosed, but they may not be sure who diagnosed them. I think even something that I see often as seeing a lot of kids with CVI is families will come in already with a diagnosis of CVI outside of us, and then it's an accurate diagnosis, but I think at that point they get the diagnosis and then they're not followed for how to best support their child after that. So that's why I think getting together groups like us today and really just trying to educate not just the doctors, but therapists, teachers, anyone who's going to come in contact with kids with CVI of how we're supposed to best help these kids. So they're not just given a diagnosis where the parents don't understand what that means and they can actually have kind of an action plan of how to help their kids and a team to help their kids. Because I think that's kind of a common thing that we see as well, unfortunately.
And I'd like to chime in, and I know I've talked about it, but cviscotland.org has these little videos that are like a minute and a half. And if people like to watch videos, and it's Gordon Dutton, and he's just fun to listen to. And he talks about CVI and gives you little bite size, like, what is it? And the way he describes it, is really digestible. And I think it's a good resource for parents if they're kind of looking at, how do I understand this a little bit?